Drug-induced movement disorders, clinical recognition and management. Drug-induced movement disorders is a group of iatrogenic syndromes resulting from medications that alter dopaminergic transmission. Drug-induced movement disorders, or DMDs, arise primarily from dopamine receptor blockade or imbalance within the basal ganglia. They are most often associated with antipsychotics, antiemetics, and occasionally antidepressants or antiepileptics. Recognition is critical, as early identification can prevent chronic and sometimes irreversible sequelae. Acute dystonia. Acute dystonia typically occurs within hours to days of initiating or increasing a dopamine-blocking agent, especially high-potency typical antipsychotics. Patients may present with sustained, painful contractions of the neck, face, jaw, or ocular muscles. Immediate intramuscular or intravenous anticholinergic. Benztropine 1 to 2 mg or diphenhydramine 25 to 50 mg. Follow with oral anticholinergic prophylaxis for 48 to 72 hours to prevent recurrence. Akathisia. Akathisia presents as an internal sense of restlessness with observable motor agitation. It often appears within days to weeks of exposure to antipsychotics or SSRIs.
Management. Reduce dose or switch to a lower-risk agent such as quetiapine or clozapine. Beta blockers, particularly propranolol 30 to 120 mg per day, are first line. Benzodiazepines such as lorazepam can provide adjunctive relief. Serotonin 2A antagonists like mirtazapine or cyproheptadine have emerging evidence for refractory cases.
Drug-induced Parkinsonism. Drug-induced Parkinsonism resembles idiopathic Parkinson's disease, with bradykinesia, rigidity, and resting tremor. Onset typically occurs weeks to months after exposure, especially in older adults and females.
Discontinue or substitute the offending drug if feasible. Anticholinergics, benztropine, trihexyphenidyl, can provide symptomatic benefit. Amantadine 100 mg twice daily is another evidence-supported option. Levodopa is generally ineffective and may worsen psychiatric symptoms.
Tardive dyskinesia (TD) is characterized by repetitive involuntary movements, commonly of the tongue, lips, or face, emerging after months or years of dopamine blockade. Pathophysiology involves dopamine receptor hypersensitivity and maladaptive synaptic plasticity.
Treatment. VMAT2 inhibitors are FDA-approved first-line therapies, valbenazine, starting at 40 or 60 or 80 mg daily, deutetrabenazine, titrated from 12 mg per day to an effective maintenance dose. Switching to clozapine may reduce symptoms in some patients. Avoid unnecessary use of anticholinergics, which may worsen TD.
Drug-induced tremor can result from lithium valproate SSRIs or beta-adrenergic agonists. The tremor is usually postural or action-related.
Management. Dose reduction or substitution. Propranolol remains the gold standard for medication-induced tremor. For lithium-related tremor, maintain levels at the lower therapeutic range and consider extended-release formulations.
To minimize risk, use the lowest effective dose of dopamine-blocking drugs. Monitor regularly using scales such as the AIMS for TD and the Barnes-Akathisia scale. Educate patients to report early symptoms of abnormal movement. Early detection and prompt action remain the best strategy for preserving quality of life and neurologic function. Drug-induced movement disorders are predictable, preventable, and, if recognized early, often reversible. As clinicians, our vigilance transforms pharmacologic precision into patient safety.